Thank you. Okay, so thanks for the introduction. Really kind introduction on my behalf. I could barely recognize most things about myself. But I've been a health partner for nearly 20 years. Balaji Krishnan, who's sitting by me, is going to do most of the talking about the cool patient-facing stuff that we do. My job will be to give a quick overview for the organization. I'm someone that likes long, wordy statements. So the slide that you see in front of you is a mission statement for our department. Obviously, as an organization, we have a mission, vision, value statement, but we created one for our own department. And just want to share with this group. We are having a quick discussion before this group got together, and Dr. Krishnan was talking about wanting to be the best in the Twin Cities, and we truly believe that. We believe that we have the right folks and the right culture, but we really want to showcase the work that we do in our organization, be the best heart program throughout this area. So I think the olden days we said from the valley to the prairie, and now we say from central Minnesota to western Wisconsin, but we truly believe we're the best, and we want people to know about it and help us get better and take good care of patients in our community. We move on to the next slide. A quick overview of the leadership of the group. We have what's called a dyad structure, which is common across the Health Partners organization for clinical leadership. And so Dr. Wheeler, who is a nephrologist, is my immediate leader. I work with Jess Beckman, who is on the call. And so she and I co-direct or co-lead this department. We work very closely with Chuck Pinkerman, who's been at Methodist for about 16 or 17 years. So the three of us our roles span across the organization. We have medical directors and operation manager dyad partners on each side. So what you see is kind of a focus mainly on the west side, because most of our talk is going to focus on work on the west side. Locally, when we say east versus west, west is Methodist via in our in-reach clinics. East is the legacy health partners, the regions at Western Wisconsin locations in Lakeview, just for folks to know. Let me move on to the next slide unless folks have any questions on these parts. Side profile picture of Methodist Hospital. On the west side, as I mentioned, we have 14 general cardiologists, 4 interventionists, and now 5 cardiac electrophysiologists. So it's a pretty large group. They work with a team of 20 plus advanced practice clinicians. And I did mention Cross River in the support staff line because as we've grown together, the two sides of the organization are sharing resources. And so a lot of our support staff actually takes calls all the way from one edge of the organization to the other. So these 200 support staff support physicians and clinicians on both sides of the river. Move on to the next slide. Lots of clinicians, not going to go down all the names, but we highlighted a couple of names because they're relatively new to the west side. And the fun part is, this again goes to our one care group culture here. Dr. Mohandas and Dr. Moriarty are physicians who have really worked at Regions or Health Partners Legacy East for a while. Dr. Moriarty is moving actually next week to the west side, and Dr. Mohandas already has. So one advantage of being integrated now is that folks can make decisions that work for their personal and clinical work-life balance, and we share talent across the organization. Special call out to EP because EP is a really well-regarded practice at Bobby Ward. I think it's Robert Ward, as on the slide, is the most recent hire, is already flourishing in our practice. So this is just a snapshot of all the clinicians who are west-facing, so to speak. We'll keep moving. We do. Between the two sides, we do pretty much everything a cardiology program does in Twin Cities with the exception of LVADs and transplants. So LVADs are one step, say mechanical support. We don't do that. Those go to institutions like the university. But short of that, we do everything on both sides of the river for the most part. There are a couple cool things that are at EP on the west side, and Balaji will be talking about them later, laser leads being one of those cases. And then on the east side, we have an ECMO program. ECMO is a form of heart bypass. It bypasses the heart and lungs when the heart and lungs are not working. And we have a program that is the only one in the east side of regions. And what's cool is we are trying to work and create a system where patients who need this at Methodist can get started on the circuit and be transferred to regions for care. So these are patients who have cardiac arrests, which are otherwise life-threatening. And we are hoping to have a completely in-house cardiac arrest care program within the system that spans from one side to the other. So I just put those two highlights, but really, like I said, apart from transplants and ventricular assist devices, we do everything within our organization. We'll keep moving. Balaji?
And so the thing is, I think from one of our previous meetings, our hope and still belief is that we are the best program. We want to continue to build on that. And this is a 10-year plan that Jess had put together with the whole hope that we'll eventually have a standalone facility of our own, move and improve our services to adding more physicians, cardiologists, electrophysiologists. This is a really exciting 10-year growth plan, and I think we're already hitting on multiple of these achievements as we see the time go along. Next. And so, the main key things for me to focus on today is, most people know me as this high energy character, right? And so I'm bound to hold that energy together for this presentation, but I'm so excited about the future, without doubt, particularly because I come within the spectrum of interventional cardiologists. That fits within the spectrum of electrophysiologists. We deal with the electrical aspects of the heart through procedures and medicines too. And then we'll also talk a little bit about the interventional cardiologists. They deal, as what we simply put, plumbing issues and valve issues of the heart. Again, interventional kind of sort of procedures, all focused on providing patients here with the best technology that exists, and potentially even offering people what's next generation. And so within our group ourselves, we've added another lab within the last year. We're using this technology, which has been seen in the newspapers already. So the Star Tribune, and it's called pulse field ablation. Our most recent hire, Dr. Bobby Ward, who we talked about, is from the Mayo Clinic. So we have expertise now that is coming from what they're already in the front end of technology doing to what we are able to offer our patients. We're doing other exciting things that even the Mayo Clinic and us, I'll show you some work that we're doing integrated wise. We're actually a little further forward than they are, which just makes me excited about it. So we're using next generation pacemaker technology, next generation catheter ablation technology, this idea of closing the left atrial appendage for patients who can't take blood thinners. We're also on the forefront of what is being done there. And so next slide. So from an interventional cardiology, we'll skip further a little to the next one in terms of what they're doing, that is next generation, is being able to do valve type surgeries through interventional procedures by basically using your blood vessels to fix the tricuspid valve, which was very challenging to do without open heart surgery. The same thing as they moved on to doing things with what's called the MitraClip, with fixing the mitral valve with that technology. And so again, the immense talent that's within this organization is unbelievable with what we're able to offer patients, which is next generation. My goal today is to show some of the work that's also being done in the non-invasive technology stuff, which Dr. Kaul will talk about here in just a second, is what we're looking forward to offering our patients with the heart flow technology. Go ahead.
Yeah, thank you, Balaji. So much as Balaji loves the interventional, the procedural stuff, which I do not do. I do the side of medications and diagnostics, so this is kind of my area of passion. And I would say that if you think of how cardiology does diagnostics, the focus has always been on things like ultrasounds or echocardiograms and stress tests. And those remain the bedrock of how we do diagnostics, so figuring out patient conditions. But we have nowadays what's called advanced cardiac imaging, which is cardiac CAT scans and cardiac MRIs, which are really mind-blowing in how much more detail they provide and how much more specificity they provide in making diagnoses and managing conditions. So that's really also going to be a big area of focus for us in the next few years. On the region side, we now have what is probably the second busiest advanced cardiac program in the Twin Cities. We're probably just behind, well, I should not name our competitors. We're just behind the giant hospital in Chicago in Minneapolis. And we really want to elevate the program on the west side as well. We do cardiac CT and cardiac MR here, but I think there's immense scope for growth to support this part of the community as well. So this is just a laundry list of things we'd love to do. We're not going to go over specifics unless folks have questions. So we'll move on to the next slide. So yeah, CT scans, MRIs, and nuclear scans are the three big kinds of imaging technology we use. One area of particular need is cardiac nuclear medicine. The irony is nuclear medicine is not a very new imaging technology, but it's a technology that remains and has a lot of great use. But that's something that we will need to figure out how to fund in the near future for the West Side. So we move on. We have a prevention clinic, and that's really strong on the West Side. We have Laura Ross, who's directed the prevention clinic for years, also does a lot of research work and outreach work, and we have a physician, Courtney Beckler, who also does work in prevention. So very solid reputation on the West Side. We hope to replicate that on the East Side as well. We'll on the next slide, and that's just a picture of, there's actually the pictures from the East Side, that region's a bunch of us sitting and listening into a cross-river meeting, and Laura Ross was presenting on prevention from the West Side. So we've done a few of these cross-river meetings. We're trying to do them at a reasonably good frequency to share things that all of us need to know, all updates, and get to know each other better. So that's a picture of us listening in to Laura talk about prevention. So we'll move on to the next slide. We'll skip this one. And Balaji will take on the EP.
And so that's the thing, is that, from a side of innovation, technology, and patient care, things are growing not just linearly, they're growing exponentially. And we've seen that within our electrophysiology volumes. the non-invasive volumes, the cardiac cath lab, and this is just to show you a sample that, until 2020, you could see the growth, but then just watch what happened from 2020 to 2024, and it continues. And so it just tells you that there is a need within the patients and the patient population for what we're offering. But again, what we want to offer is the absolute best, and if not, maybe even give patients, which I'll talk about in the future, what's next in research, what's next in innovation, and hopefully I'll excite you with what we have. Yeah, next.
Since we are focused on 8 foundations is what I hear, this is just a little snapshot of where we are. So really from Hutchinson in central Minnesota all the way up to Amory. In fact, I go to Amory for my clinic. I go there twice a month. And I've gone to Amory for 15 years, and it's always a breath of fresh air to go to a small community where everybody knows you and all the patients know you. So it's really nice for me to go to Amory. I don't know if, do you do any in-reach or outreach, Balaji?
I do at Maple Grove,
okay.
So in-reach. And as you can see, the map extends all the way to Hutchinson, Olivia on the west, and which is really the coverage of what we offer. And then that's the key with the One Care group, is that we span practically Minnesota and then now Western Wisconsin, which is really where I think the importance with what we are able to do together.
We'll move on to the next slide. Big priorities for us. Cardiology is always ambitious and aspirational. We are big dreamers, and many of the dreams have come true, and that's why we love what we do, but we have more dreams that will need support. The big things for us, one thing that we have recently achieved, and actually with the help of the foundations, is a CME event. So on the right half of the slide, you'll see a mention of an annual cross-organizational CME event. So we actually had that on the 6th of February. I give a lot of credit to Balaji Krishnan here for really wanting to do this. He was so persistent to the point that I would call it harassment. He said, son, we've got to do this, we got to do this, we got to do this. I said, Balaji, there's a lot going on. But he infected me transiently with enthusiasm. This is our first Cross River event, and we had nearly 100 participants that signed up. Because it was our first year, we didn't have a hybrid or a virtual option, so it's only in person. We still got 100 folks to come to the Nagley Auditorium. We got really good feedback. We hope to make this an annual event, and this was partly supported by foundation dollars, so we really appreciate that. The big challenges in cardiology in general is how we provide care to our patients in the future, and I see 2 big areas that are going to be important. One is the challenge with many of the newer modalities of cardiac treatment are not super well funded or reimbursed, and that is going to be a challenge. And the other challenge is going to be that the old model of brick and mortar buildings, people showing up in clinic, being seen for visits, and then a provider calling a prescription, that care is going to continue, but it's not going to be what grows fast. It's going to be virtual clinics, it's going to be telemedicine, it's going to be patients who monitor their own health. And those are also new things in medicine that the healthcare economic system has not figured out how to regulate, manage, and most importantly, reimburse. So how do we provide these new and expensive technologies to our patients, and how do you provide care to patients at home in newer models are the big challenges facing cardiology in the future. But those are working with those are our big priorities for next year. So we'll move on to the next slide.
Yeah, and then to mention, Andrew Walsh found this as important, and he found her to come and integrate this event, which means, again, it speaks to what and how important it is for us to have a one group event that highlights all of the talent and all of our providers and brings in all of our primary care providers. But again, this is a vision that's not just singular, it's multiple people came together, but supported so many ways by the organization, including Andrea Walsh, because it meant a lot to this organization to do that event. And so again, this is just a slide that shows how we're growing, which is again, 41 to 43% in a year is not normal. It means that we're taking care of our patients, we're able to reach out through all of our outreach programs to all of these patients, but we're all motivated to caring for people. We're very, very motivated for it. And so I think the desire is internal, the desire is external. It means that I think we are in an amazing organization. And so the things that I'm highlighting today is really the things that I think from a forefront of where we're going with innovation is that, you know, we want to be a center of excellence. And that was one of the major things we highlighted to start with. And of the things we do is something called catheter ablation. So this is the way we treat electrical abnormalities inside the heart. And our major achievements is that, again, it's not just about doing the best, but actually being the best of the best. And so we're the only center in the Twin Cities to be able to offer these procedures without using X-ray technology. We rely heavily on our mapping technology. We've developed such levels of high expertise amongst us. We collaborate amongst the 5 of us to reach and have reached that thing. So no X-ray for any of these types of ablation procedures. It's one only center doing so. where only one of two centers able to do an ablation and put a Watchman device at the same time. All right, they have basically been set up as two separate procedures, but two separate procedures means two separate risks and things that come with it. And again, with success comes more success, and that's one of the reasons why we are one of the highest volume centers for treating atrial fibrillation with this technology, which I'll highlight in a second, called pulse field ablation technology, which as I show in the slides here, with not damaging collateral structures. It takes care of just what you need to within the heart without affecting things outside the heart. And again, I'll show you, I love pictures. So the next slide. This shows us as being the first center in the state with the first 100 cases. We achieved 100 cases within 5 months with this specific technology, which is a technology that J&J specifically offers. There's multiple companies that do so, but we do so because we don't have to use X-ray technology in order to offer our patients this pulse field technology. Again, this highlights the entire group that has done this and achieved this achievement, and we're already way past 100 cases already now, but it just shows, again, the excitement that we have for being together and doing great work together. Next slide. And so again, this is the idea of sort of what we call the Watchman device or the amulet device. These are competing devices, but the idea is that we should be able to treat patients who have risks for taking blood thinners by using these devices to close them. But as I mentioned now, Watchman devices have been around for 8 years, but we're only one of two centers now able to do them together with an ablation. Next slide. And again, it's not just us being able to show that we're doing good work within. We've been invited to places to actually highlight the work that we've been doing. And so most recently we presented at this conference, which is specifically for APPs, to show that we are able to be a nationally renowned program for providing these Watchman procedures without needing to have a probe down your mouth. We are able to put a specific catheter, which uses intracardiac ultrasound, to actually be able to deploy these devices. So it can be done with patients who are just basically at a dentist's office, getting sedation as if they're relaxed about the whole experience, but they're not under general anesthesia and don't have to have extra things done to them. And so again, it speaks to the remarkable work we're doing here. Next. And part of it is that, again, innovation means it's a procedure that requires some level of risk. And so when we do procedures, we take a lot of respect to what that behind this is a patient that we have to take great care of. So we created this quality initiative program, which we call the Zero Goal Projects, which is bringing down the risk of things down to zero, not 0.1, 0.2%, but down to zero. And so with so many of these things I talked about, not using X-ray, we've actually been able to show with our pacemaker procedures now that people don't have bleeding around their hearts by the specific way in which we're implanting these devices. We moved along with that technique about 4 years ago, and we've shown that technique actually has no and zero risk of, and we've documented that in terms of what we've been able to do. We had one of these things after 5 years of being able to do this procedure, which is a remarkable thing, which we call the pneumothorax. And then the last thing is, when we do devices, patients are going in with the hope that it will be completely successful. But there are times where the anatomy is not right. There are times where the devices are not built for that specific type of anatomy. But then, as a whole group with the non-invasive imaging groups, we've been able to image patients before to determine whether it's actually going to work for them or not. And so with that, in 2 years of using this particular imaging technology, we've had 0 failed implants. Again, it's remarkable statistics with the intent that we're not looking to just benefit patients, but we're not looking to cause harm. We want to do this as safely as possible. And so the key with the laser lead extraction program is one of the biggest highlights of one of the work that we've done as a collaboration between Dr. Schultz and I, with the ideas that can we do these procedures? They're very dangerous procedures. It's actually acceptable within this field to have a death in 100 cases because of how risky these particular procedures are. Next slide. But we are the only program in the state of Minnesota that has had no deaths doing this procedure in 7 years. All right, and that speaks enormously to what we've been able to accomplish as a group. And that's why we're not only a nationally renowned center, but we are an internationally renowned center where we're able to train physicians from around the world. I got invited 3 years ago to go to India to launch actually their biggest program in laser lead extraction. And this is the team that sort of put it together. I'm going back again in June. We're having a little conference get together for actually the country of India for many people to attend. But it just speaks again. we are Methodist Hospital, we are health partners, we can do such work that can be learned and known of, internationally, just because of the statistics of how well we can do it. Next. And so again, it's just parts of sort of the idea of care is innovation, great care, safely done. But research is sort of what's next, all right? And so that's where we decided that we're going to get further involved. And so Laura Ross presented, he presented about some of the work that's being done in the prevention space with some of the next generation drugs that are being offered for managing cholesterol and lowering cholesterol. We're involved in actually one of the largest trials, actually probably going to be the largest trial done. You'll find out these results probably towards the second half of this year, but 20,000 patients got enrolled in the whole world in 260 sites. And we are actually one of the top 10 recruiting sites in the United States. All right, which speaks again to the population of patients we take care of. This will be the largest cardiology trial done at HealthPartners. I'm expecting this trial to actually come out in the New England Journal of Medicine because of just sort of the scope of what this trial is able to achieve. So again, it just speaks that we are moving further ahead, even in that front of what's next, what we can offer. So we're doing trials in research with devices too. So this is something called the Backbeat trial. We've completed another trial, which we did in 2025. So there's more work that will continue to be done in all spaces of care of medicine. Next. And that's the last piece, which we're personally most proud of, is we created an actual procedure from scratch to what it is today at Methodist Hospital. And so this is actually the removal of masses within the heart, and I'll show you a picture of what it means with the use of this intracardiac ultrasound. We developed this procedure out of a very challenging case, but that's sometimes how innovation happens. You're in a space that you're stuck between, multiple rocks, and you have to find a way to get out. All right? And we started with that, and now we've grown to being a program which even the Mayo Clinic has invited us to speak about the success of what we've been able to do. And so this is sort of a talk I gave last year at Mayo Clinic for what we've been able to do with this particular technology. What it means otherwise, if patients had this particular condition, they would go to surgery. It would mean that they would have to open heart surgery. But how about a 1-hour procedure, like you're at a dentist's office where you're awake, you're basically just relaxed, instead of open heart surgery. All right, and so that's what 2019 started to what we've been able to do. Next slide. And so we published about this too. Next slide. And so the idea is simple, that now, there's actually companies that have innovated and come up with actual devices that now are able to do this, which is what we talked about, sort of that 1-hour procedure where we're actually able to use this catheter, which has a big funnel at the end of it. Simply put, it looks like a vacuum cleaner. But it's a vacuum cleaner that sucks blood very fast, and you have to be certain you do so very cautiously and judiciously. And again, no deaths in any of the procedures we've done with this particular type of technology and what we've innovated here. Next slide. And you can actually see in this slide here that the top left slide shows you that there's this big mass that's attached, and I know she has the mouse, but it's basically attached to what we call the aortic valve. And then on the top right, basically you can see this big vacuum system coming and sucking this thing out. And for all it looks like, it doesn't look like much. It looks like, a mealy worm that you pulled out of someone's heart, but this was the difference between the patient dying from a large clot going to their lungs and being alive the next day. All right. So innovation comes from many ways. Sort of necessity is the mother of invention, but can that mother invention come here at Methodist Hospital? And it did, and that's how you start. You start from a small idea, you build a group of people, you build a lot of talent around you, and now you become a nationally or internationally known program for this type of work. Go ahead. And so we've done this for so many cases. People come from many places referred specifically for this. Our hope is not to just be the only place doing this particular thing, but to educate, which is why the future of thinking of this is in this year to train others at the HealthPartners East Side, because they have the talent, there's no question. We have tremendous brain power, we have tremendous talent. Is now to spread the wealth and spread the ideas, spread the education. And so we've done remarkable work. It's time to grow. Next. And so, I think in highlighting all of these things, I'm hoping to show you what remarkable work has been done, but not just that, but a preview for the future.
Thank you for that. So I'm Pete McNabb. I'm the Grants Program Manager at Park Nicollet Foundation, and just hopping in here at the tail end of this presentation to add a couple of comments about some of the work and partnership we've already been able to do with our cardiology partners here at HealthPartners. So while my role in grant making takes place specifically at Park Nicollet and Methodist, I will say a couple words about the work that's happened at some of our other Health Partners hospitals that have cardiology presence at. I think just at the outset, I have to say I'm totally infected by the spirit and the energy in this room right now and the topic at hand. I think that everything you heard today about the system-based approach and knowledge sharing that our cardiology department has and has cultivated at HealthPartners is really typifies the attitude that we're trying to embody here at the HealthPartners family of foundations. And so that makes cardiology a very special opportunity for us as foundations to come together and to be creative and to try and support the opportunities that we just heard described in the last half hour, of which are manifold and exciting. And the scale of that support is something that I am very interested in as well, because while there's opportunities for capital and space and huge innovations, there's also opportunities for patient special needs and small items that can make a big difference in folks who are recovering from some of these procedures, who are in cardiac rehab, and that's actually where we'll start. So I'm just going to go through a couple of slides about the types of grants that have been made in the Health Partners system. The first is at Hudson Hospital. The cardiac rehab team there was awarded a grant from the Hudson Hospital Foundation to procure a weight bench for their cardiac rehab facility for folks who are recovering from procedures and heart surgeries that can start to get into rehab and build back strength after these pretty intense operations, and to get back the quality of life that they were looking for, in which the care that they received at Health Partners has helped them achieve. So again, a small item that we were able to provide for cardiac rehab makes a huge difference in our patient experience and getting back all the way to the quality of life that they're wanting and seeking care for. The next item is something that happened at Westfield Hospital out of New Richmond, Wisconsin. A similar scope and range. It's something that is really important for patient special needs and addresses an equity problem for folks who can't always afford these types of durable medical devices, which help patients kind of monitor and track their progress and recovery and goal setting for their cardiac health. So home blood pressure monitors are a small thing that the foundations are able to provide that make a big impact here at Westfields. And since 2022, Westfields has provided over 180 home blood pressure monitors for those patients that are involved in monitoring their blood pressure and trying to hit blood pressure goals so as to maintain their longevity and have better heart-related outcomes. This is work that we've also done at Methodist, and I'm sure we'll see elsewhere. A great opportunity to support patients. A little goes a long way, and it makes a huge difference. The last thing I want to mention, you heard a little bit about from Dr. Krishnan, but the CME event that was hosted just last week or a couple weeks ago at Nagley Auditorium, this system-based Park Nic Health Partners Cardiovascular Conference. Super cool, seminal event. I hope it's the first annual. I hope we'll see that again and again and again. An amazing time for our physicians and cardiologists to come together and knowledge share and sort of cultivate a real program that I think you heard a lot about earlier today, and is just a very wonderful chance for our physicians to be able to educate one another and share those innovations and share the work that they are doing to celebrate and advance it. And I had the opportunity when we were reviewing this grant to see the schedule and the approach to this was so cool. It was like this kind of really densely scheduled day of these quick talks, you know, this kind of rolling rapid fire structure that you see described below that I'm sure was just like maximally interesting to everybody that was involved. So I might have to sit in next time, although I'll go over my head, I'm sure. But anyways, so these are a couple things, you know, there's more to say. There's the heartbeat clinic that you've heard about in the past. There's pre and post holding capital space enlargements at Methodist Hospital. There's everything that you heard described earlier with regard to equipment and other innovation that we want to do. This is an opportunity for our donors to get involved in, and it's just a joy to make grants with this department and to see the work and to hear back about the impact. So thank you again to Dr. Krishnan and Dr. Kaul for being here today. So.
Excellent. Well, thank you, Pete and Dr. Kaul and Dr. Krishnan. We will open it up for questions, and just as a friendly reminder, if you can just enter them into the Q&A. If you think of any, please let us know. But in the meantime, you were, first of all, sharing such excellent information, all of you. And could you speak more to, with research and innovation, like futuristically speaking, how can philanthropy potentially play a role in some of the studies that you guys that you've talked about, or any other future plans that you have in that regard?
Yeah, good question. I'll take that quick, and then if Balaji, if you have something to add, feel free. Clinician time is expensive, and finding ways to do research that can be funded are challenging. So traditionally, research is either funded by companies that make drugs or devices because they have a vested interest in developing drugs or devices, or they're funded by the government or nonprofits, or run by academic institutions. But the role of philanthropic work in large nonprofits like us that are not truly academic is huge. So we could do a lot more research if there was the ability to support clinicians who say, you know what, yep, I'll do a little bit less clinical work, but I'm fascinated by this disease entity or by this prospect for this treatment. So helping support clinician time for research is going to be a great way to help. Would be one example I can think of.
Yeah, no, I think along those lines, if anything, I should speak about Laura Ross. An inspiration for me in basically getting involved in some levels of research and things like that. The Heartbeat Clinic speaks to how foundation and philanthropy actually helps, because sometimes you have an individual idea, but it is not of a kind that's industry supported or of that kind of nature, but it needs to be done. But just starting with a small amount of philanthropic foundation support to help build something that now is a randomized program, right? And there's so many individuals that have those ideas, that have that vision, but not something that an industry or a pharmaceutical company is half interested in supporting. And so that's where philanthropy actually makes a difference, where people can apply to the foundation for smaller funds to do individual, in guided research things with sort of simpler ideas for people, even within the Park Nicollet sort of space. Even this was specifically for Park Nicollet employees, which is a brilliant idea, right? It was found, the money was to support a little bit of her time, but also to support having Park Nicollet. So it supports everyone here. So it's not just the foundation, we're looking at a larger group of patients, but we're looking at ourselves. People who work here, can they benefit from some of the ideas that come from within? All right, so I think that's where smaller research projects, individually driven physician, she's a physician assistant. And unbelievable that even someone like her can charge a project. And that's sort of the remarkable nature of talent. It does not need to be centered in one specific space. It can come from anywhere.
I love that. Thank you both. Looks like we have a couple more questions here. One moment. Pull up. Perfect. Okay, so one of the first questions is, first of all, excellent presentation. You talked about many new innovations which is enabled by funding. If you received the funding, what are the top 3 areas where you would spend that in order of priority, and what drives that priority?
So I should not let Dr. Krishnan go first, because Dr. Krishnan is so ambitious, he will take any and all funding for all his projects, and I try to look out for the larger team, so maybe I'll go first. So thank you for the question and the interest. And honestly, it's difficult to give an answer because a lot depends on what the scope of the funding is and what kind of money and what kind of duration we're talking about. But I would say the big things that mattered was going back to the world of imaging. If we need to work on a nuclear camera facility equipment on the Methodist side, nuclear cardiology and stress testing are really the core of a lot of what we do in cardiology. And unfortunately, that's one area where we are facing a challenge. We have one nuclear camera at Methodist, so if that one camera were to go down, then we'd have to send patients to one of the clinic sites that has it, or send them across the river, or send them to another institution, which is obviously not preferable for a million different reasons. Funding research and education will always be core to what we do, and that is something we always love. A couple of things that I really care about is trying to figure out how to use artificial intelligence in clinical care. And artificial intelligence is moving very rapidly in medicine, but it's such a new field that many systems are very leery about investing in it yet. So you talk to a bunch of folks from industry and vendors, and they have all these amazing products that can rapidly improve care, but we need to have some risk appetite in investing in them. So one really cool idea that is supported by a bunch of different companies, but is not really funded in any good way, is how can you look back at old CT scans, or CAT scans of patients, scans already done in the past, and look for clues about future heart disease. Because if you specks of calcium or cholesterol build up in the heart on a CT scan done, say 2 or 3 years ago, well, 2 or 3 years ago, we ignored that information because we didn't know first how to collect it or how to analyze it and do something with it very systematically. But AI can now basically replace that human effort and say, hey, you know, Dr. So-and-so, you have 15 patients who had CAT scans the last 2 years of your lungs, and you didn't notice this, and the radiologist didn't notice this because you have very tiny spicules of calcium, but you may want to talk to them and make sure they're not smoking, their cholesterol's under control, they're getting exercise, blah, blah, blah. So AI is a growing area, in my opinion. Balaji, I'll let Balaji take it from here because he take all the rest of any philanthropy we get.
No, I think
So I had to go first.
That's the key. I think he was very specific about things that are practical that are needed now, and I think that's sort of a very important thing to have. I'm of the kind where if you start with grand ideas, then maybe you'll come out with a clear idea of 1 or 2 practical things. From that perspective, I think the number one thing is like all this innovation, a lot of the innovation that you've seen supported was supported by industry and pharmacy, which is great. That allows us to bring research here. But I think the idea and the core of individual investigators getting seed funding, $5,000 or $10,000 for an individual idea for a small, for even a cohort of 50 patients, is a very powerful thing because it allows people to start their pathway to being an investigator. Right? There's a lot of people standing in the sidelines thinking about it, but are not able to get into it unless you get into a space as large as I am in, and you need a lot of support to do that. But to get that starting point is where the foundation means a lot. For an individual to say, can I start with a small idea, $5,000, $10,000 for a small research project, give you a nice clear grant for doing that, and you will see at least 5 to 10 budding people, young investigators coming along with a research idea. And the second thing is the education piece. The big value point is we did this wonderful conference, but we had no trainees attend, right? Because the key thing was that this was a CME event that was supported by attendees. There was no outside industry support of any kind. And I think that's where philanthropy will make a big difference, is that provide a small fund for these types of major events to allow people in the internal medicine training programs, the family medicine training programs, a full grant that's unrestricted for them to get all their attendees to attend. And I think that sort of is a very powerful thing, education, right? So again, innovation is all cool, it's research, it's just next generation stuff, but if you don't educate the next generation, then I think then we're missing out on what we can do for the future. So that's sort of my grand view of what we can do and bring down a lot of people that are sitting on the sidelines, that we can bring forth, and then again, that's the concept of exponential growth, right? One person trains 2 people, they train 2 people, and then you just see that grow.
Beautifully said by you both.
Yeah.
Thank you so much. And we do have another question here, if I can ask. So they had said, it's clear we have an enormous amount of talent with our existing cardiology teams across the HealthPartners system. You were sort of speaking to this, but I just want to make sure we didn't miss anything else. What efforts are being made to recruit new talent of such high caliber? Are we known yet as a desirable place of employment to continue this existing work?
I'll take a first shot at that. So I'll take the second question first. I say absolutely, I would say we're a desirable place for employment. I'm a little biased because of my leadership role, but I will tell you that we on both sides of the river educate fellows from the University of Minnesota. So fellows are physicians who finished medical school, then the residency in medicine, and now training in cardiology. And it's really nice to see that health regions and Methodist are usually the top two sites for where they want to work if they're going to stay in the Twin Cities. And since my role spans the river, I get to see them interview on both sides and tell us how they both think these are the two best places. So we know that this is a welcoming environment that people want to join. A few years ago on the east side, we had a nearly existential challenge and lost several physicians during COVID. But then we recruited 10 physicians, and we actually recruited 2 more physicians back to the organization. They had left HealthPartners and come back. So I do think they're desirable. On the west side, we got a Mayo graduate last year join the EP program, and we have 2 other physicians move from the east, as I mentioned, and 3 physicians joined from other networks in Minnesota in the last few years. So I'd say we are desirable. What are we doing to recruit new talent? I'll actually go to where I think the foundations can help us here. We are so strong clinically, but I think in the research side, there's still options. We could do more to teach clinicians and healthcare workers in many different ways in our organization, but we don't have formal pathways for research and protected time for teaching. So we sometimes do miss out on great candidates who would say, we'd love to come here, but you would not be able to will you give me protected time for research or give me protected time for teaching? Well, that's not how our system is set up based on the daily business needs. So that's an area where if there was foundation support to help someone who says, I'm going to bring this awesome research portfolio, then those are ways that the foundation would support us. So I think that's one area of opportunity we would have.
And then I think, in my view, success begets success, and what we've done here within I've been here since 2017, is that from a perspective of cardiology, I think we are the most desirable program for people to come in. And so even for the position that we had in electrophysiology, we had multiple applicants. We struggle with who to give the job to, really. And it comes down to that, is that, when people have heard of the work we've been doing here, and which we'll continue to do so, I think I don't have major concerns from that perspective. But also I think the piece about education does matter. And our hope here is that not only are we recruiting physicians that are mid-career or late career, we're recruiting physicians that are early career, people that hopefully we have a pathway and a long road for people that can practice for another 20, 30 years here. So also on the front of innovation and whatnot, I want to reassure everyone here that we have a grand plan that's not 10 years, it's 20 years, all right, because of many of the people that we believe are going to stay here for at least 20 years because of how we plan on growing and where the practice is going.
Wonderful.
Yeah.
And it's okay if I ask you guys one more question?
We have the time. I just want to make sure folks who are online have the time.
Oh, perfect. Thank you. So knowing that all cardiac care cannot be delivered by cardiologists, what new skills and/or equipment do you see primary care should be developing to assist with cardiac care?
Oh, good question. I'm curious who had that question, but a couple of different things, some of which are already happening. So POCUS is an acronym for point of care ultrasound. And that's basically using ultrasound at the bedside for patients who need a diagnosis quickly made. Traditionally, POCUS or ultrasound is done with echoes. So we have these big clunky machines, we have them in our heart centers. But now physicians everywhere, not just in primary care, but in the ED and critical care areas, are learning how to use portable ultrasound machines to do a quick study and say, is there some really big heart problem going on? So that's an area where primary care, for example, is expanding their technical expertise to understand and study the heart. I think collaborating with not just cardiology, but collaborating across the specialty spectrum in providing care without bringing patients into an office. Like, how do you use e-consults or e-visits or virtual visits to say, hey, I have this patient, he's really challenging. I have a feeling that my plan is a really good plan in place, but can you give me an idea? Those things, team-based care would be great because, like I said, the old-fashioned model of you see a patient, you handle the situation as much as you can. When you feel you can't handle this anymore, you say, okay, now go and see a specialist. That model is going to have to change. We can't have that. The system doesn't have the capacity, whether in primary care or in specialty care, to quote unquote pass the buck around. So how do you develop team-based models and then come up with a system where someone can pick the phone and say, I'm seeing so-and-so in clinic right now, can you take a look at this? So I think that those are going to be things where we can expand in a way that actually makes the patient feel they're taken care of by a team.
And that's the other thing, is I think we're also, like, amongst the spectrum of things that we're doing, we're now allowing primary care physicians to prescribe things that ideally were limited by cardiologists. So monitors, that ideally you had to go see a cardiologist for before you got it and all that kind of stuff. I think through a little bit of education, a little bit of collaboration now, we've been able to give primary care providers across. So this is one of the things with monitors. Now, the two things are, one, that primary care can prescribe it. Two, it can be sent to them by mail. There's a little set of instructions about how to stick it on, and there you go. It's sent back to mail, but it's finally read by a cardiologist who will then give you a specific thing about this is not worried or worrisome, or this is something to worry about, send them to a cardiologist. So the whole idea of sort of opening up the system to allow primary care providers to provide patients care directly for things that we thought always needed a cardiologist. So that's part of sort of our growth thing, and this is sort of one of the major sort of examples of how we've expanded that. But same thing with lipid management. You don't need to see an expert just to manage your cholesterol, but this is sort of the cross collaboration thing, but also making sure that in the process you've created a nice collaborative experience.
Wonderful. Well, thank you both, and thank you, Pete, for your time today, and thank you everyone for joining us. Your guys' passion for the work you do is infectious, and we really appreciate you taking the time to present to our group.
Awesome. Thank you for having us.
Thank you.
Enjoyed it.
Thank you. Yeah.
Have a great day, everyone.
Thank you.